Bonjour, bienvenue à tout le monde. Merci de nous accompagner à notre webinaire aujourd'hui, une collaboration entre la Fédération des sciences humaines et la Société royale du Canada. Welcome everyone and thank you for joining today's webinar, Putting the Humanities to Work for Canadians, Mettre les sciences humaines au service de la santé des Canadiens. Je m'appelle Cynthia Milton. I'm Cynthia Milton from the University of Victoria, where I am the Associate Vice President of Research. It's my great pleasure to welcome you all to today's webinar. I'm speaking to you today from University of Victoria, which is on the lands of the Songhees and Esquimalt people on whose traditional territory UVic stands, and Lekwungen and Wasanich peoples whose historical relationship continues to these beautiful lands to this day. So we're hoping to move this conversation along on putting the humanities to work for the health of Canadians. Today's webinar will discuss the findings and policy recommendations from the recent Royal Society of Canada report, the Humanities and Health Policy, and how they can be put into practice. This report is available on the website of the Société royale du Canada, the Royal Society of Canada. So before we begin, I have a few housekeeping notes. Today we are offering simultaneous interpretation in English and in French, as well as closed captioning in both languages. These options can be found at the bottom of your screen. As well, the conversation will be recorded and there will be a Q&A session at the end of the webinar. You can submit your questions at any time by typing them into the Q&A box that is part of the Zoom function. So we have five speakers today, 5 conférenciers, and I will introduce each just prior to their comments. Each will speak for about 6 minutes, and then we will move on to the Q&A. So let me start first by presenting Dr. Maya Goldenberg. Dr. Goldenberg is an associate professor of philosophy in the Department of Philosophy at the University of Guelph, where she is cross-appointed with the Bachelor of Arts and Science. Maya, thank you very much for coming today.
Nice to be here. So if I can start, since I'm the starting person, I wanted to say a little bit about the pressing question of what is it that the health humanities can offer to health policy, public health practice as well. And I guess it would be helpful to first distinguish the humanities from, let's say, the social sciences. So the humanities is the study of the human condition. So questions about meaning, questions about existence, and we study this through various media: art, film, music, literature. We have classics, languages, philosophy, and religion. So roughly it's the study of what people have created over time, whether those are belief systems or artworks, and expressions that have been made about culture. So this, of course, is distinct from, let's say, the social sciences, which studies patterns of human behavior. Within the humanities, there is quite a large area of health humanities, and humanities disciplines approach health and illness as part of the human condition. And this turns out to be a very valuable way of thinking about health and illness, given that we have entered a pandemic era. At least that's what's been said by Anthony Fauci and other high-level virologists and epidemiologists. So instead of thinking of pandemics as something that is disruptive and then we go back to normal, it's more valuable and more helpful to think about it as part of our normal trajectory. And of course, historians have been saying this for a while, that we tend to forget crises very quickly in that desire to go back to normal. Doing that, however, doesn't serve us well, because forgetting, it doesn't allow us to learn from the past. We're better prepared when we learn from past experiences, and humanities gives us unique tools to do that. And we argue in the report that humanities disciplines are often underutilized in health policy development, and even more so in health technology research and implementation, even though these tools are quite valuable. So if I could say a little bit about what those humanities tools are that I keep referring to are, they are, first of all, historical perspectives. Humanities is largely driven by looking into the past. And of course, our history informs our current social and cultural context, the current context in which science and technology exist and where it evolves. And these historical perspectives could be better mobilized to help in understanding the forces that shape contemporary perceptions, concerns, assumptions about new policy issues or new technology. So that's a historical view. Over in philosophy, philosophers of health do what philosophers do, which is examining our assumptions, our inferences, the concepts that we use when we communicate. And those are the things that inform health practice and policy. And by doing that, we sometimes uncover inconsistencies, problematic usage, and we can often challenge those ways, those sort of common ways of thinking or common ways of speaking about things, and introduce new ways to think and speak about issues that affect policies. Then, of course, there's ethical analysis as well. And we also draw, that's just history and philosophy, we draw from literature, from film, from religion, from languages, which we know are valuable resources for increasing the effectiveness and inclusiveness of policies. It can also improve our education, our outreach, our communications on public health, because humanities have those tools to decode cultural meanings, make sense of cultural idioms, the meanings behind words and images, analysis of rhetoric, and with those tools you can develop much more nuanced messaging. The final piece that humanities offers is amazing archives of information and experiences, but I want to leave that to my colleague Erica Dick to talk more about archives.
Thank you very much, Maya. So Erica Dick will speak next. Erica is a professor and a Canadian Research Chair in History of Health and Social Justice at the University of Saskatchewan. Thank you, Erica.
Thank you, Cynthia. And if you bear with me just one moment, I will share my screen here and have a few slides. I'm coming to you from Treaty 6 territory in the homeland of the Métis at the University of Saskatchewan in Saskatoon, and I'm really pleased to be part of this conversation and to have had the opportunity to work with Maya and others on this report. And I'm going to also acknowledge my collaborator and friend Nazim Muharajin. I haven't told him that we're friends yet, but I hope that we are after working on this. It's one of the benefits of working across these collaborative projects that really bring community into focus, as we recognize quite quickly that actually we are all in this together across disciplines and across different ways that we've experienced the pandemic and how we want to remember it. So my part or one of the contributions we made to the report, and what I'll share with you briefly today, is some of the work we were doing in Saskatchewan that was collaboratively funded by SSHRC, or the Social Sciences and Humanities Research Foundation, and CIHR, the Canadian Institute of Health Research. And together we assembled a team of a sort of interdisciplinary team of scholars and many, many community partners to try to take stock of that lesson that Maya has already pointed us to, the concern that we might forget the pandemic or forget the lessons that we could take from this. So we applied our historical skills to sort of set up the architecture for this project. And I'll run through a few ideas briefly. You can check out more detail, of course, on the website here, which we've called Remember, Rebuild Saskatchewan. So not only taking stock of that, of the experiences, but also looking for ways to improve upon the delivery of public health services and also community infrastructure. Our objectives are broad-based, and they really draw from some of these humanities approaches to thinking about how we might structure this research. We relied on qualitative research, and that part was largely driven by interviews, but also quantitative research that we did through partnership with Canadian Mental Health Association as one example, and Nazim will talk a little bit more about that in his section. And then we've built community partnerships, and having just come from a meeting just minutes before landing here, one of the takeaway issues there that I really want to emphasize, and that I think the humanities has a lot to offer us, is thinking about the trust that is involved in thinking about health decisions and health applications that come from those policies. Working with communities over the past few years, and as we think about lessons going forward, trust and risk assessment has become really important, and how we as humanities scholars can start to unpack or decode some of those has become a really valuable tool. And of course, working together, we can also contribute to policy advocacy, and we have writing skills, it turns out, in the humanities that can be helpful for, particularly we've been working with frontline service providers who certainly have good writing skills, but less time. Along the way, we've encountered or uncovered other partners. So I'll just point to a couple here. Archives Unleashed, which has really helped us to take stock of the digital turn in the way the communication has been on display in the pandemic. And I'll give a really specific example of that in just a moment. We've also partnered with COVID in the House of Old, which was a series of museum exhibits that traveled across Canada, drawing attention to long-term care and often some of the resilience of people living in those spaces, not just some of the catastrophic stories, although those are also very much on display. So I'll give you two quick examples of some of the work that's come from this that draws from humanities perspectives. Now, this may not look like a typical humanities depiction, but this is something I'm really excited to share because I didn't do it. So I get to ventriloquize this brilliant PhD student's work who downloaded Twitter during the pandemic. I believe that in the end, he sifted through and downloaded what we think might be tweets that came from Saskatchewan, as much as one can tell. You can see along the side here, if anyone's familiar with Saskatchewan politics, there are some sort of key political characters on that list. What he did with this, though, is try to measure how conversations on Twitter were shaping reactions to policies. So this is digital history or digital humanities at its work. Here's a quick example of where we start to see some really fine-tuned analyses that are really helpful in how we assess the way that decisions were made. On the left-hand side, you'll see tweets from our Premier, Scott Moe, who may get more followers as a result of being Premier. What you're seeing here on your screen are reactions to his tweets. What you see on the right-hand side is the leader of the opposition, our NDP leader at the time, Ryan Miley, himself a family doctor. And you can see that there just was very little engagement with the leader of the opposition. This is helpful for us to understand as we think about measuring the impact of these communication strategies. And you may be wondering about that spike on Scott Moe's side. That would be the convoy that went to Ottawa. That's right around the convoy time. So this kind of digital humanities work allows us to now do some more fine-grained analyses or focus us on areas within the pandemic to sort of disaggregate the timeline. And finally, I'm going to show you a quick example, and maybe this will play while I'm talking. We also put together a digital memorial that tried to combat some of the quantitative information that was coming at us during the pandemic about the numbers of people or the caseloads and the mortality rates. In doing so, we drew from publicly available information and then also had an open portal that people could volunteer information, families. This is just a quick set of screenshots that you can see of the way that this digital memorial functions to draw attention to some of the lives lost during the pandemic that allow us to get at some of the stories and really some of the diversity of the lives that were lost. We also recognize that a lot of people don't use obituaries anymore, which is another takeaway from this project. But suffice to say, some of our humanities perspectives on capturing the history of this is to draw attention to the individuals, the talents, the skills, the memories that have been lost as a result of the pandemic. And finally, I just want to give thanks to the team that has, our core team that has worked tirelessly to put together our COVID archive and our Build Back Better site and the ongoing community meetings that we are having as we try to make some now general policy recommendations and also continue to build those trusting relationships with our community partners. And I think I will end there other than to just give a snapshot of some of the kinds of community organizations we've been working with. This is not entirely comprehensive, but it gives you a sense of university, vaccine development, but also a number of labor unions and frontline service providers, whether that's long-term care, food banks, Salvation Army, and housing services, as we try to capture the impact of the pandemic on these service providers. Thank you.
Thank you, Erica.
Keep sharing because Nazim is next and I have his slides.
Okay, thanks for the IT support as well. So I'm happy to invite Nazim Muhajarine to speak next. He's the professor and epidemiologist in the community health and epidemiology in the College of Medicine at the University of Saskatchewan and director of the Saskatchewan Population Health and Evaluation Research Unit. Thank you, Nazim.
Thank you very much, Cynthia, for the introduction. And Erica, thank you very much for setting this up very nicely. And I'm also joining everyone from Saskatoon, Treaty 6 territory, and also the land of Métis people. And I'm an immigrant to this land, having immigrated from Sri Lanka. What I'm going to do is I'm going to focus on one of the two strands of the Remember, Rebuild Saskatchewan project that Erica started us off on. The strand that I'm going to focus on is the Build Back Better that I lead. And this project is focused on understanding the wider social impact and specifically mental health, substance use, housing insecurity, and food insecurity associated with COVID. And the Build Back Better project is often referred to as our health data project among ourselves because we did implement a population survey of Saskatchewan adults in late 2022. And we have used these quantitative data to do complex analysis to unpack these 4 outcomes that I mentioned. Build Back Better is indeed a project that collected stories from those who provide services and those who receive services in the communities across Saskatchewan and how they navigated the pandemic. The numbers and the stories from the Build Back Better have been used by community organizations, by health authorities to take measure of the fuller impact, not just only the COVID outcomes and COVID deaths, but the full impact of the pandemic and to consider resource allocation and program implementation decisions moving forward. Next slide, Erica. So in the brief time I have, I'm going to focus on one report, just one report from the Build Back Better project. This is titled Lessons Learned from the Pandemic. As Erica said, just minutes before the start of this webinar, we just arrived from a community forum and really very good, rich discussions there. And the genesis of this report actually occurred in one of these community forums in a meeting with our community partners. One executive director wondered what lessons we take away from the way that community-based organizations pivoted and delivered services to clients in the height of the pandemic. There were some creative ways services were delivered, not only in Saskatoon, but across Canada, perhaps across the world. This executive director wondered what, if any, of the ways that service organizations change what they do would stay going forward. What would we preserve? What would we hold on to that we would refer to as better ways to do things? What innovations will stay and which ones will revert to the pre-pandemic way of doing things? Next slide. So inspired by our community partners' musings, we set out to answer these 3 questions in the report. And I will not read this, it's very straightforward. And the next slide. So this report, all of 35 pages, has nuggets of insights that are useful, especially for those in working with people who need services and support. I hope you could see this on your screen. On my screen, it is a little bit out of focus. This report is full of revealing quotes. And because of time limits, I can't share this with you. But I'm going to go right to the punchline with this slide. This particular investigation led to 3 themes of findings, named innovations, On the top there left, approaches and navigation. Let's just pick one set of findings shown here, approaches to service delivery. These are the ways that service providers change their ways of delivering services during the pandemic. In so doing, they maintain service delivery and optimize the health and well-being of people they serve. They focus on person-centered services, meeting people where they're at, and that's the only way that they could meet people. And focus on psychological health and safety, not only just physical health and infection, and coordinated service delivery among a continuum of care, preparation, and prevention. Next slide, please. The findings presented in this report showcase the experience, adaptability, and resilience displayed by service providers and people who access services during the pandemic. They also highlighted the shortcomings in our existing systems to offer services to community members. Collectively, these insights provide invaluable lessons to improve the equity and sustainability of service delivery systems. Next slide, please. So I want to end with this slide and some reflections. This is an ongoing, sort of work in progress. On the left here, I am suggesting some of the benefits from putting humanities, back into health research, as we have done in this project. Research questions have clear social value. In fact, the questions started with our community partners. It is their questions that we are addressing in this report, for example. Methods are more human-centered, not only surveys, those are fairly standard, but also talking to people, listening to their stories and telling their stories. Community participation is robust. And on the right, some suggested challenges or pitfalls or musings, that we need to pay attention to as we put humanities back in health. So we perhaps can unpack that a little bit later in the Q&A. Thank you.
Thank you very much, Nazim. We'll now invite Nathan Nicol to give his presentation. Nathan is the director of the Manitoba Centre for Health Policy and Associate Professor of Community Health Sciences at the University of Manitoba. He's a scientist at the Children's Hospital Research Institute of Manitoba and the associate editor of the International Breastfeeding Journal. Thank you very much, Nathan.
Thank you. And next slide. Just want to begin by acknowledging that I'm coming to you today from Treaty 1 territory, which the traditional homeland of the Anishinaabe, the Cree, Ojibwe, Dakota, and Dene peoples, and it's also the homeland of the Red River Métis Nation. Just by personal positioning, I am a newcomer to Canada. I moved here about 10 years ago, and I'm originally from Southern California with Latino heritage. Next slide, please. I'm going to be talking to you just a little bit about some work that happened in partnership with the Manitoba Métis Fédération and the Manitoba Centre for Health Policy, looking at some of the outcomes linked with the rollout of vaccines, COVID vaccines here in Manitoba, and starting to map out some future explorations with community members. So to begin with, next slide. The Manitoba Centre for Health Policy hosts and our project was led by a team including the Minister of Health from the Manitoba Métis Fédération, Chartrand, the Director of Health, Olena Kloss, myself, and Dr. Michelle Dreger, who is a Métis scholar. And so what we started off with was understanding that the experiences of Manitoba Métis have really been shaped by historical interactions with the Canadian government, with the provincial government, and that those past interactions are going to shape what took place when the vaccines were rolled out here in Manitoba. Next slide. So in order for the first part of our project, we wanted to understand what some of the patterns of vaccine uptake were from a whole population level. We leveraged data that's housed in the Manitoba Population Research Data Repository at the Manitoba Center for Health Policy, and it's a collection of information that documents virtually every individual who lives in Manitoba, documents all of their contacts with the healthcare system. And so through that, we were able to go into the repository and find all records of COVID vaccines that were administered to Métis citizens or citizens of the Manitoba Métis Federation, and link that with some other information related to social and structural determinants to understand not only the trends in the pandemic in terms of COVID infections, but also to understand the vaccine uptake at a population level. Next slide, please. And so what we did was we looked at what was happening with the vaccine rollout once they became available. Here in Manitoba, Métis citizens were not initially prioritized when the first dose of the vaccine came out. And what we found when we looked into the data was that on average, Métis citizens were getting vaccinated about 1 day later than the rest of Manitoba population. In the late May, early summer of the initial rollout of the vaccines, at that point, the provincial government prioritized Métis citizens to be vaccinated a lot ahead of the rest of the province. And once that prioritization took place, it went from being vaccines taking 1 day later, which was what took place during the first dose, to Métis citizens getting vaccinated about 1 to 1.5 days sooner than their counterparts. And this investigation looked at things like, did that vary by age? Did that vary by where people lived in the province, different health status? And we consistently found that by prioritizing Métis citizens, they were able to get vaccinated sooner. Next slide, please. But one of the things that came out during the quantitative phase was some interesting patterns that made us want to look a little bit deeper into what were some of the community experiences with this vaccine rollout. And so we engaged in some preliminary community consultation and key informant interviews. And what we heard, going back to what Erica mentioned, was that there was a real distrust within the communities for the provincial government's initial rollout of vaccines. And some of that distrust came from confusing messaging that came out during the pandemic from the provincial government. Some of the distrust came from inconsistent messaging that arose. And so as a result of some of these stories that we were starting to hear from Métis citizens, the team went and secured some additional funding, which we just got access to begin looking at, well, what were some of these outcomes of the systemic and structural racism that permeates Manitoba as it relates to Métis citizens. And so this next phase is just underway, where we're engaging in community dialogues to understand historical interactions with the healthcare system here in Manitoba, and whether and how those influenced access to vaccines during the pandemic. And we're also doing a quantitative piece to understand, well, what would have happened if these systems of systemic and structural racism did not exist in Manitoba, or how much harm would have been avoided in the absence of this systemic and structural racism. So blending together understanding of culture and interactions with the system with quantitative methods to get a holistic understanding of what Métis citizens' experiences with the pandemic were. And so that work is also being led by Minister Chartrand, Director Klaas, Dr. Dreger, and myself. Next slide. And so that brings me to the end, and I'll pass it off to our other presenters.
Great, thank you very much, Nathan. Our last presenter is Dr. Sean Bagshaw. So Sean is a professor and chair of the Department of Critical Care Medicine at the Faculty of Medicine and Dentistry at the University of Alberta. Thank you, Sean.
Thank you, Cynthia. It's a pleasure to be here. First, I'd like to acknowledge that I also come from Treaty 6 territory and the homeland of the Métis. Second, I do want to extend a thank you to Drs. Jones and Wright for the invitation to contribute to this policy briefing, and to my fellow members, Drs. Dick Goldenberg, who we heard from today, and Dr. Holmes, who didn't join us. But also importantly to the Royal Society of Canada for allowing focus on the importance of humanities in the context of the COVID-19 pandemic. By training, I'm an intensive care physician. I'm a clinician scientist. And I would say I am not an expert necessarily in humanities as it would pertain to pandemics or other public health issues. I think my contribution to the policy briefing is from the lens of the bedside and at the coalface during the pandemic. And it's in this context that I was hoping that I could offer some comment. You know, during the pandemic, if I wasn't working at the bedside, I was often, sequestered at home, and I found myself with some opportunity to read about prior pandemics. And one of the most outstanding books I read was The Great Influenza by John Barry, which I'm sure is familiar to many. But what was amazing was to read the historical accounts in that book that occurred during the 1918-1919 influenza pandemic that could very easily have been superimposed on what we saw and what was happening in 2020 and 2022. And I think this nicely speaks to Maya's point during her presentation around historical perspectives and perhaps not using humanities and having not used them to learn that it's a missed opportunity. So some of the things that I think we witnessed widespread implementation of public health measures, of course, physical distancing, masking, and there was some impact on civil liberties. We witnessed, public protests to these public health measures. We witnessed vocal anti-science and vaccine hesitancy and anti-vaccination commentaries. We also witnessed challenges in the clarity of public health messaging. And that seemed to propagate widespread misinformation of unproven and discredited interventions. And I can attest to my own anecdotes about how many times I was asked from family members of critically ill patients about why they were not receiving hydroxychloroquine or why they were not receiving ivermectin. And some got quite upset, quite emotional, and quite angry, and it seemed to propagate some distrust to some extent. I think there's important differences between what we've gone through in the last few years and prior pandemics, specifically 1918, not so much pandemic H1N1 influenza or SARS, but are really important for us to emphasize, particularly, from my viewpoint on the front lines. And these might be really important learnings that we can, one, archive, but then two, advance. And some of which I think, not all, but some of which had real negative implications that I think we should not cast away to distant memory. So some positives though, like at no time in history were we able to so rapidly identify a responsible pathogen for a pandemic, even though it was novel. But we saw, along with that, really rapid mobilization of clinical trials and health evidence. I mean, unprecedented. And to some extent, while that can be viewed as a success, I think much of the public was not prepared for how fast science evolved in the context of this pandemic. We now have far greater advancements in how we can support acutely ill and critically ill patients, simple supportive care like oxygen therapy, specific interventions like antibiotics to treat bacterial infection. And if you think about 1918, so many people died during that pandemic, in part because they got secondary bacterial infections. We didn't have antibiotics then. But also the advent of intensive care that really came out of the polio pandemic in the 1950s. But to say the least, we have mechanical ventilators right now to rescue people who have overt respiratory failure. These are differences than prior pandemics, certainly going way back. we saw widespread implementation during this pandemic of visitation restriction policies, both in the acute care settings and in long care settings. And these policies, while implemented with the best of intentions, given that we were confronted with a new pathogen and a potential existential threat, to be honest, they likely had profound negative effects in retrospect. Certainly for critically ill patients, what I saw and what the other critical care healthcare staff saw pretty routinely was that patients were isolated from their families, from their loved ones, from the medical staff to some extent, because we were under gloves and masks and gowns in isolation rooms. And that was really challenging. But I would say that even amongst older and more vulnerable populations in long-term care, this was always obviously a huge challenge. And I think it did work to compound the negative effects of social isolation, which we know can be terrible for older patients. We witnessed high degrees of burnout. And I think the longer term implications of this in the acute and intensive care workforce are still being felt. Perhaps some healthcare workers anticipated retiring, but carried on out of a sense of duty and then left once things, sort of died down a little bit. But I think at the same time as well, we have fewer potentially entering the workforce. And so we have a workforce crisis right now in critical care, but also I think in acute care across the board. And I wonder if this is exacerbated by the sometimes baffling, but very angry public protests we saw about anti-lockdown, anti-public health, anti-vaccination occurring on the doorsteps of hospitals and acute care facilities when, the workers inside those facilities really were so remote from policy about those kinds of public health interventions. So I wonder what that, whether there's an interaction there. I think we also saw, importantly, about how misinformation had a far greater reach due to social media platforms. And I think Dr. Dick hinted at this, thinking about digital humanities, evaluating some of the public health response to public health interventions. But these social media platforms can algorithmically reinforce mis or distrust in public health, anti-science viewpoints, and certainly other emotions. And the final thing I'll add is that the public, in my view, clearly had challenges in understanding who was providing credible public health information in a timely fashion. But also there was a real difficulty in understanding how scientific discovery, new evidence generation, and how that evidence was integrated into better informed updates to recommend how we treat patients or prevent COVID, et cetera, in high-risk patients happened so quickly, never before in history. And I think that highlights, again, maybe a little bit of what Dr. Nichols said in his description of the vaccine rollout amongst Métis citizens in Manitoba. That could have been one of the things that we have to consider and learn from. So those are just some thoughts that I had. So hopefully we can add to that in the discussion. Thank you.
Thank you very much, Sean. Thank you to all the commentators and for your work on this policy briefing and the insights that you've brought to the importance of bringing humanities to health research. We're going to go now into a period of question and answer, and I invite people to please put your Q&As into the special box that's available to you. But in the meantime, I'd like to start with a question. I myself am an historian, and so I don't need to be convinced of the importance of humanities. I work at the University of Victoria in the research enterprise. So one of the things that I've noticed, and I think several of us in the humanities have noticed, is that we're in a strange period. So we understand, and I think you've all made this very clear in your presentations, the need for the humanities to help us tackle these pressing challenges. So we're in the pandemic era. We have more specific opioid crises that hopefully will be of shorter duration. We have concerns around planetary health. So these are all incredibly challenging issues that we're facing. But we're also in a period of decreasing enrollment in the humanities, of the shrinking of humanities faculties and the kinds of courses being offered, and kind of just a general, I fear, undermining and undervaluing of the humanities. And so I think the policy briefing that you've done and this presentation as well are part of how we put the humanities back in. But what other things can we do to put the humanities back in? How do we get the social buy-in, the political buy-in for the humanities? In my dreams, I would imagine, could we have a chief science advisor that's a chief humanities advisor? But what other things could we do and should we do? So Nazim, I see your hand is up.
Yeah, Cynthia, I will offer a couple of thoughts there very quickly. I think, first of all, historians and everyone who works in the humanities, when they are working on projects that are interdisciplinary, like ours is in Saskatchewan, you need to identify yourself as a historian. And I think it is very important to keep the identity intact and what you bring to the table, the contribution. I think it shouldn't be melded. It shouldn't be invisible. This is, maybe it's just as obvious as like. But the other thing is that we need to train young scholars, students, graduate students in humanities in interdisciplinary settings. So, one of the things that I didn't get to speak very quickly was, the manager of our project was a historian. The current manager of our project was specialized in adult pedagogy and community health. So, and I think that disciplinary setting, need to be cultivated, very early. And I think we need to make a case for funders, for mentors to be, to do that, in that interdisciplinary setting. So we need to catch them when they're young and build them from there.
Okay, thank you, Nazim. Nathan.
Actually, I think Erica had her hand up before me.
All right. Thank you, Nathan, but it doesn't matter. I'll say quickly, I think that what we saw in the pandemic was that, and Sean has touched upon this, there was good science and sometimes it wasn't enough, that the communication issues were really critical. And that's something we've learned in our community work as well, that communication has been really key. And it is one of those skills that we have, and also our capacity to sort of step back and see perspective and, draw out perspective on something that is a crisis. We're trying to look back from the crisis and measure things across a wider context, and that has turned out to be really valuable. And I think it's something that we can advocate better for ourselves, I think, as humanities scholars. But also, I think, perhaps there are lessons to be taken at the tri-council level, where we recognize the value of humanities scholarship as integrated into those kinds of interdisciplinary projects. And the mechanisms are there, but often humanities is not part of those conversations.
Thank you, Erica. Nathan, and then Maya.
Yeah. So, in addition to like all the fantastic points that were just raised, I think there's also an opportunity typically within health policy, government or policy or whatnot tends to reach out to the clinicians and to the more positivist, quantitative oriented individuals. And I think that there's a real responsibility, I'm a quantitative researcher, a real responsibility for us as quantitative researchers and clinicians to highlight where the gaps that our work has and the need for humanities to really fill out and to be brought in to make better policy. I think that we have a chance to be ambassadors and allies with our humanities colleagues and point out when humanities is missing, and that it needs to be at the table in order for us to have the best policy approaches and solutions to pandemics and health issues. So I think some of the responsibility also lies on us within this space.
Great. Thanks, Nathan. Maya.
I was going to make an argument that sort of bridged what Nathan said and Eric said. I certainly think more public humanities is a valuable thing. So that's humanities writing and speaking to the public, whether it's in public talks or writing on online, open access online forums like the conversation. And in the work, you get to show what a humanities scholar can offer to contemporary issues. At the same time, it's difficult to do that because humanities departments are being squeezed. The cultural message that STEM is going to save us has been around for a long time. And because of that, humanities gets additionally sidelined some more as somehow irrelevant. And perhaps some humanities scholars even do that they sort of turn inwards towards our own interesting but internal issues and debates rather than facing outwards. So more public humanities, and just like scientists are being encouraged to do more public facing work, humanities scholars should be doing the same to really advocate for ourselves and hopefully bring in more resources to do that. Because I will say, in my own professional setting, humanities is being squeezed so hard that we can barely keep up with demand. We're not able to, we have, for example, on my campus, we have students from outside of the College of Arts who would like to take philosophy courses. We don't have seats for them. So we need to make the case, but we also need some assistance to actually do the work we'd like to do.
Thank you, Maya. Sean. You're on mute.
I agree with all the comments so far. I think, maybe I'll just bring the lens back towards medical education, and maybe there's an opportunity for us to think about how to embed, strong examples of the strength and power of humanities in medical education. There is, not that I'm, there is an arts and humanities and health and medicine program at the University of Alberta in the Faculty of Medicine and Dentistry, led by Pamela Brett McLean, who I believe is PhD in philosophy. But this embeds a bit of a program in undergraduate medical education, but I'm not clear whether its mission is aligned with, let's say, the recommendations of the policy briefing, whereby it's actually, providing an opportunity for medical students, medical residents, learners to understand the important historical perspective of that humanities brings in understanding these public health issues, these pandemics. Good examples as well, the opioid sort of crisis, planetary health, etc. So that's some, another angle that I think we could probably, pay some attention to that might serve the greater purpose here.
Thank you, Sean. So you allude to another question I have, which is how to prioritize these kinds of collaborations between health sciences and health humanities. So several of you have spoken about different collaborations that one could imagine and one could do. And if we were to prioritize them, how might we go about that? Where should we start first, or put our energies in at this stage?
Well, it's already the case that a lot of the Tri-Council funding is looking for interdisciplinary teams.
Yeah.
I feel that that's already changed, at least in my discipline, which is philosophy, where it made philosophers need to think more about contemporary issues because that's where the funding was. The next step, of course, is to make these interdisciplinary teams. But I've heard this from many who have been on these teams, and I've been on them too, is sometimes we get together and then we don't know how to do it. We don't know what to do when we're there. So it seems like we need a little bit of training about how to actually integrate our work together. We have many brilliant examples like Erica's and Nazim's work where we can certainly learn from examples, but it'd be nice if we had more guidance on how to set it up for success.
Nazim.
No, it's a tough question, Cynthia, but I think Maya's right. I think it's already happening. New Frontiers funding initiative is a good example where they both all three councils are funding together. But I think it takes a certain type of personality. I think, I mean, to be quite honest, I mean, it takes a certain type of personality, researcher and community member to actually sort of work across the home discipline, you know, the home discipline area, the core disciplinary area. It takes a lot of patience, a high degree of trust. I mean, trust among and between, you know, colleagues and between university researchers and community members. It's difficult to create these relationships, trust relationships, while you're doing the project. You know, I mean, you know, I think it has to be there to some extent. There has to be an openness. So therein actually, you know, goes back to that training issue, you know, training, you know, whether it is in medical education or graduate students, you know, I think we have to envision a different way of training future researchers and scholars. And, you know, and I think that's where it begins.
Thanks, Nazim. Nathan.
Yeah, thanks. Nazim was actually ended where my mind was just around the idea of what type of training are we providing? If I think about in graduate school, the focus really is on you as an independent individual researcher, whether it's in the humanities or social sciences or health sciences, and making that transition of demonstrating one's capacity to be an independent researcher to being part of a team, which is, I think, essential within this type of work. It is something that not everyone can navigate well. And so my mind was starting to think, does that need to be considered? Like, if this is an intentional direction that needs to be pursued, does that ability to work within a team need to be considered even during the admissions process, or as we're starting to think about folks entering into graduate school? So that was the first area that my mind was going. And my second, you asked about like what types of partnerships or what types of work should be prioritized within this space. And like there's an element I think that has come out of our conversation just around understanding culture as it relates to interactions within the healthcare system, or interactions with pandemic messaging and pandemic policy that could be really interesting to both pursue from a research perspective, but I think could, as we understand like culture, like with ethnography or from anthropological research, can help us think, how do we move forward with some of these policies a little bit more effectively? So that was the other space my mind was going, but I agree with Nazim, that was a challenging question and I'm still processing it.
Thank you. And Erica.
Thank you. Yeah, I'm sort of taking cues from the community meeting we were just at. And I think that one of the things we've done over the past 100 or so years is we've gotten really good at putting our disciplines into their own little boxes. And we almost have to unlearn the cultures of those disciplines in order to find ways of working together, because we fundamentally think differently. And that is both an asset and a challenge when it comes to coming up with some kind of structure for decision making. You know, I want Sean to be decisive when I come to him with an emergency medical situation. And like, I'm not the person you want to come to as I say, well, you know, it's complicated and there's a lot of nuanced perspectives to consider. Both of those have value, but they come at different costs and at different times. And so it's difficult to assess the kind of, you know, prioritization that you give. When do you want a nuanced perspective and, you know, a really thoughtful, reflective, slow examination, slow research, maybe even? And when do you want a decisive, but we might get mad later decision? And I think we need to sort of build in infrastructure to help us think about how we make decisions as a team that doesn't have a kind of tokenized whether it's, the science perspective is tokenized or the humanities perspective is tokenized, but how do we start to think about collaborating in meaningful ways that actually appreciate the different cultures of thinking and decision-making that go into what makes our disciplines rich and interesting?
Right. Thank you, Erica. I'm going to give the last question to Julia Wright from Dalhousie, and then you can answer her question. So Julia, go ahead.
Thank you. Thank you, everyone, for a wonderful panel. There's so much to think about. I was wondering, in my experience working across disciplines and in ocean humanities as well as in health humanities, the biggest challenge is language. We don't just have different terms, we have different methodologies, and we have different ways of writing and different notions of what constitutes persuasive writing. So those are absolutely barriers. But I found that what can often drag us over those barriers is an ethical commitment to some kind of larger goal. Be it academic ethics, improving the conversation, a public policy goal. And I wonder if you have any thoughts around how that can help drive a more positive conversation to get us over those kinds of superficial, really, divisions at a time when we are being so ethically challenged by the mess that surround us politically and socially and so on. So I just sort of throw that out there.
Thanks, Julia. Yeah, Erica, go ahead.
I'll just say this really quickly, and I'm stealing this from our community members this morning, but they described this as a reciprocal set of decision-making processes. And I think that's something we can learn from them. And the example they gave was, firefighters working with poverty coalition people, to put it in a generic way. They require different sets of skills to answer the problem, and the problems that they have are, different in scale and in urgency. And yet working together in a reciprocal way really help them to deal with things. And I think we could take some lessons from that into the academy as well, and think about where reciprocity lies in our relationships.
Yeah, if I could just add too, I think one of the problems that we can run into when we start thinking about that kind of goal, alleviating poverty, improving vaccine take-up in underserved populations and so on, is that we are often told that as academics we're supposed to be objective. And that can create a kind of an ethical discomfort with saying, I believe in the public good on this particular front, and I can mobilize my research to help us achieve some success with that if I can collaborate with other people who also share that goal. So it kind of asks us to get outside of that notion of academic objectivity, perhaps in ways that are troubling.
So we're at the end of our time now, unfortunately, but I hope that this to be an ongoing conversation as we all work to putting the humanities back into public health, back into our decision-making on a lot of different fronts as we confront these different challenges ahead of us. So thank you to all the speakers for your time and your work. Thank you for the policy briefing that you've put together. And I wish you much luck and success, and I look forward to future collaborations.
Thank you very much.
Thank you.
Merci à tous et à toutes.
Thank you.
Thank you, merci.
Bye-bye.